Good afternoon, everyone. Welcome to the VCU Department of Internal Medicine Grand Rounds. Thank you all for being here. Today is May 26th, 2022. Today is a very special Grand Rounds. It's hosted by the Department of Internal Medicine, and we have our 5 internal medicine chiefs here who will each give a reflection and comment over the last year. So before I introduce them further, just a couple of quick things. Thank you, everybody, for filling out the surveys for planning for next year. We had, I think, 80, 85 responses. Help us a little bit with planning for next year. So thank you for that. We have 2 more grand rounds for the remainder of the year on June 2nd on lung cancer. And on June 9th will be about evaluation reviews and clerkship from our educational office. And then lastly, just the CME code will be posted in the chat. We'll be recorded, will be up on the website. We're working on processes to improve that for next year. So thank you for your patience. We appreciate that. So today's title is Merging Innovations and Humanism Within Medicine. And our 5 internal medicine chief residents will be talking about the revitalization of educational traditions, describing innovations in medical education, and recognizing opportunities for humanism in medicine throughout this. So the way this will work, we'll pass it over to the chiefs. They'll each take an opportunity to reflect. And at the end, we hope to save about 10 minutes or so for a Q&A session. So please utilize the chat function or ask to unmute yourself to ask questions. So I'll go ahead and introduce each of our speakers, and then we'll turn it over to them for the lecture. So Dr. Zoe Zhang, she was born in China and grew up in New York City. She went to college at the University of Chicago, majoring in biological sciences, completing an honors thesis in endocrinology. She took a gap year conducting biomedical research at the University of Chicago prior to starting medical school at Duke University. She completed her residency in internal medicine last year here at VCU in 2021, is now completing her chief year and will be moving on to San Diego for a Hem/Onc fellowship at the University of California in San Diego. Congratulations, Dr. Zhang. We appreciate your service here. Dr. Neha Hippalgaonkar. Dr. Neha Hippalgaonkar is currently serving as the chief medical resident here. She obtained her medical degree at Charles Schmidt College of Medicine at FAU in Boca Raton, Florida in 2018. She completed her residency here last year in 2021. And she will be moving to Chicago this summer, where she plans to pursue hematology oncology at the University of Illinois in Chicago. She has a special interest in the study of cancer health disparities. Congratulations, and thank you for your service here. Dr. Raslan, she completed her undergraduate and medical studies at the American University in Beirut, Lebanon. She completed her residency also here in VCU 2021 and is now completing her chief year. She was the conference chief for this past year. Her plan is to pursue nephrology fellowship at Duke with a concentration in medical education, and will be starting this year in July. Congratulations. Thank you for your service. Dr. Taylor Wood. Dr. Wood is the current ambulatory chief medical resident. He previously attended college and medical school at the University of Louisville and will be returning and starting his cardiology fellowship at the University of Kentucky this summer. Congratulations, and thank you for your service and leadership. Dr. Taylor Pence. Dr. Pence is the current chief resident for quality improvement and patient safety. He completed his undergraduate degree at Virginia Tech before coming to Richmond for medical school and went on to do his internal medicine residency training. And I guess he likes Richmond so much that he's going to stick around next year. He's going to be a hospitalist and the associate program director of quality improvement and patient safety for the program. So congratulations to you as well, and thank you for your leadership. So I'm going to turn it over to you guys for a discussion and briefing here. And thank you so much for all your leadership over this year. It's been a year of transition, and we appreciate all your leadership. Thank you.
Yeah, thank you, Dr. Bergen, for the introduction. I'll share our slides now. We'll get started.
Thank you, everyone. We're so excited to be here for our Chief Grand Rounds. We're going to be talking about merging innovations and humanism within resident education. Again, I'm Neha Hippalgaonkar, and I am the current resident chief.
Hi, everyone. I'm Zoe Zhang. I'm the current intern chief.
And I'm Rasha, and I'm the conference chief.
And I'm Taylor Wood, current ambulatory chief.
And I'm Taylor Pence, the current chief for quality improvement and patient safety. So going to our objectives for our grand rounds today, we'd really like to impart an appreciation of some revitalization of our educational traditions that we have within the internal medicine residency training program. Describe some new innovations that we've had within the department, as well as really highlight and recognize our opportunities for bringing humanism back to medicine, especially in the age of physical distancing. An overview of how we plan to accomplish this is we have our three kind of major objectives here, and you'll see listed below those are a number of initiatives, educational activities that we've been doing throughout the year that we feel like fit into each of those objectives. I will be talking about our emergency response training and our senior QI rotation and how those fit into our objective of revitalization. So our emergency response training, this is a really special activity that we do with our residents, an initiative that we've done. It initially was developed by Jonathan Hilliard, who was one of our prior chief residents in quality and safety at my role. And as residents have really loved it, and I think it's probably one of the more fun things that we get to do throughout the year. To help kind of frame this a little bit better and some of our other topics later, reviewing our progressive training model that we have within the department, I think would be helpful. So you can see we have kind of our three stages of progressive training. We have a learner, which you can say would roughly correlate to those kind of in their earlier years of training, so DGY 1. Then we have our manager rotation, which is kind of that next step, some of those learners that are independent. And then our PGY 3s, which are our teachers and leaders, who have people who are dependent upon them. So you can see throughout all of this is our idea of growing autonomy. As part of that, our emergency response training is really developed to help those managers on their rotation. So this is designed for our residents who are at their medical and cardiac ICU rotations during their second year, which are VA-based rotations. We have a 2-hour session, which starts out as a didactic portion. During that time, we give residents a framework of how to respond to an emergent medical event. We also then review some frequent medical emergencies that they might encounter within the hospital, review some things like ACLS, and then we give an opportunity to apply that framework and those skills and that review in a high fidelity simulation center and go through some case scenarios. During their first session, they're able to go through a few scenarios as well as complete that didactic portion, but then we have additional opportunities later in the year that they are able to come back and just repeat scenarios and do new scenarios to get additional practice. So improvements that we've made this year and some of those revitalizations that we've done. So I wanted to really apply the high reliability framework and some of those high reliability principles to this training initiative. First of those would be physician engagement. With that, we wanted to increase engagement with residents and really make this a part of their curriculum and their experience during those manager ICU rotations. So through this, we increased the number of sessions that we have. As all things with COVID, it was difficult to have frequent sessions, but we had 8 sessions last year, and this year we were able to expand that out to 22 different sessions. We then also wanted to apply the principle of leadership engagement to this. And so with that, I connected with leaders of both of those rotations, both of those units. And they were very supportive in supporting our residents to take time away from clinical care to be able to participate in these sessions and enhance their own skills. That was further supported by the HR principle of sensitivity to operations. And I was personally involved with both the Code Blue and Combined Specialty Care committees. Those committees are heavily involved with reviewing responses to emergent events. And through that, we were able to provide a rapid feedback mechanism to modify our curriculum and enhance some of those areas that we had room for improvement or were seen as potential opportunities for failure. In terms of assessing how our residents responded to these events or to these training sessions and what they were able to get out of them, We did pre and post surveys, and I'll have a number of slides. All of them will be oriented with our pre-assessment on the left and our post-assessment on the right, with the legend being below. So these questions were looking at resident comfort during these emergent events. You can see the dark blue and orange are representing that they're feeling more unprepared, whereas the gray and yellow are either somewhat prepared or very prepared. These are a few representative questions. Globally, all of our results were very positive, and you can see through these, residents are feeling more comfortable in doing things like identifying resources, identifying their role, and responding to a code, feeling more comfortable in responding to a code, as well as feeling more comfortable in responding to a rapid response event. We also wanted to look at resident knowledge and what they were getting out of these sessions. So you can see we have our pre and post assessments here as well, with our green representing correct answers to some of those knowledge-based questions. Some of these are related to that framework that we were building, which is standardized across the VA, but is also applicable to any medical emergency, as well as some of those metrics looking at comfort with ACLS and identifying members of the The next thing I'd like to talk about is our revitalization of our QI rotation. So this is a curriculum that's been built for years, largely with the help of our current AD for QI, Derek Kleiner, as well as all of the other any other members involved with that, including past and prior chief residents. So I have the goals for our rotation listed here that you can read, but globally, this is a 2-week dedicated rotation that gives residents an opportunity to participate in self-guided rotation, which is a number of activities that enhance both their learning about QI, exposure to QI, both healthcare systems, and then gives them an opportunity to participate in QI initiatives in our health system. As part of that, we have a longitudinal project that each rotator contributes to during their time on the rotation and carries that forward. One of the ways that we've revitalized this is a somewhat new portion of our curriculum is we've developed a shared way to really keep everybody up to date on that progress, share with prior and current rotators as well as future rotators within the program. Really, we're hoping to increase our engagement with the material and showing residents how their quality initiatives can be impactful to the health system. We also assessed our comfort with QI material with our pre and post assessments here. This scale is a little bit different in denoting their kind of comfort with QI material, with the darker colors representing not knowing anything about QI, hadn't heard of it, whereas kind of that light blue and yellow are representing that they're comfortable with QI, and the lightest blue representing that they feel like they could give a lecture. As you can see, before and after the rotation, we see a large shift in that everybody is comfortable with QI, they've worked with the material, and over a quarter of them feel like they can give a lecture on the topic. We also looked at some attitudes related to quality improvement with an assessment here. You can see the darker colors here are listing they're agreeing or not agreeing with the statement, with those lighter colors representing that they agree or strongly agree. So here we saw improvements in residents' attitudes about wanting to know about quality metrics, feeling that they could lead a QI project, and also that their projects do generate changes if possible. And with that, I will pass it over to the other Taylor.
Thank you, Taylor. So essentially moving to further revitalization, but also touching upon a bit of the innovations that we've had this year. On reviewing our conference evaluations, they really strongly favored in-person, non-traditional, interactive formats. And so our goal really was to take that and either make virtual conferences in person or create new conferences to kind of fit those needs. And so I'll be touching upon a little bit of the great debate and Neff Madness in the revitalization category, but also some of our new conferences like Clinical Problem Solvers and our High Value Care Report. So the great debate, it's one of my favorite ones every year. And so previously was a virtual format, this time in person. It involved both inpatient and outpatient residents, so it's a pretty large audience that takes place. And it's a resident selected topic. So this one happened to be cardiology theme, which I enjoyed, but functional stress testing versus coronary CT when you're looking at CAD risk stratification. And so it's that of a typical debate format. So both these residents, Soleil and Rainey, did a fantastic job. They had opening statements, rebuttals to each other's opening statements, as well as closing statements. And that was all sort of proctored and facilitated with expert opinion from one of our resident cardiologists, Dr. Corey Trankel. We appreciate his input within this presentation. But the goal of this really was to foster curiosity, as well as offer robust conversations that were all evidence-based. We also made it a bit competitive too when we added the fact that, hey, who offered the best evidence? Let's vote for the winner. That was kind of a fun little spin at the end. Moving to our next one, which is Neph Madness. So for those that don't know Neph Madness, think of March Madness, but let's do kidney-themed sort of breaking innovative nephrology topics instead. And there's 64 of those, much like March Madness. And they kind of partner all these up in a typical sort of bracket, much like March Madness style. And what this is essentially is we have essentially this Neph Madness website that has various topics on it that are all evidence-based, and residents will select a topic. They're charged with presenting that information to the audience. And then these conversations are facilitated by one of our resident nephrologists. This year, it was Dr. Vinakova. We appreciate her assistance, as well as Dr. Kidd. And then just to add on to that, there was also some kidney-themed, or at least Neph Madness-themed baked goods. You can see on the right some glomeruli there that are expertly baked by Dr. Vinakova with some parasites within them. And then on the left side, Dr. Leiner, who made a wonderful ova and something cake, and it was a parasite cake in the middle when you cut into it. It was great. So we appreciate both. They're all just making it a bit more exciting, more interactive, and all of our residents really took a lot from this kidney-themed conference. One of our new conferences this year. So for those that have heard of Clinical Problem Solvers, we became part of their virtual morning report. This is newly created this year. And so essentially we had Jude. She presented an amazing case of a young male patient with HIV presenting with new renal failure. And we had Marina, as well as Jonathan, who had the very difficult task of not knowing the case beforehand and having to give their lifetime sort of thoughts to this. And these lifetime thoughts were in front of an entire audience of residents and medical students, as well as an entire virtual audience from the Clinical Problem Solvers world. And it was great because we were able to have one of the clinical problem solvers themselves facilitate that discussion, sort of break apart the salient features of the case, along with emphasizing Marina and Jonathan's points. And also the entire clinical problem solvers virtual audience were also tuning in and giving their thoughts live time. So it was amazing to see all those just incredible brains going back and forth, putting their input on the case. And then this is our next new sort of new conference we've made this year, which is our high value care inpatient report. So the goal of this was to increase the knowledge of the cost of these common labs, tests, diagnostics that we order while someone is inpatient. And the goal is not just to be cost conscious, but to offer true high value care, meaning the most bang for your buck. And so we used common cases to demonstrate this that you see in the hospital. For example, syncope. We've all admitted a syncope patient, maybe even once a week, or a patient with a PE, for example. We're able to break apart those. And our goal was to be able to use your history and exam to then guide your evidence-based workup. So when we polled our audience in the room, their general workup for the patient for the case of syncope was going to be around $8,100. With an evidence-based high-value care approach, again, not cost-conscious, but high value, it still ended up saving money at around $2,700 for a total savings of $5,300. Again, this is just one example of the cases that we had used. And again, just a goal was just increase awareness about the cost of tests that were ordered in the hospital. And do we exactly need some of these things that we're ordering? Does it really change our management when we order them? And with that, I'll pass it along to Rasha.
Thank you, Taylor. So along the theme of enhancing our diagnostic skills, and I'm going to be talking a little bit about innovation and how we merge that with humanism. So one of the studies done at Johns Hopkins University, and this is even pre-pandemic, was that they surveyed their medical interns at 2 different hospitals over 2 years, and it showed that medical interns spend really approximately 12% of their time examining and talking with patients at the bedside, and more than 40% of their time behind a computer, and with the rest of the time doing other duties that really take them away from the patient and being at the bedside. So to do this, we set out to create a faculty development course called Enhancing Physical Exam Curriculum. And our thought was that if we start with the faculty, it will trickle down to the residents and to the medical students.
So the course, we did this because we know that the physical exam is really important in creating that human connection, which thereby reduces our burnout. But we also know that, as Taylor mentioned, better diagnoses and outcomes can be achieved by doing better physical exams. So we surveyed the attendings at the beginning of their 2-week board block, and we asked them how often they teach physical exam skills at the bedside. So you see in this pie chart that very few say that they always or frequently do teach physical exam skills. And actually 9 out of 10 respondents said that they teach physical exam skills 50% of their time or less. So the structure of the course is that it was a 20-minute lecture where we picked a specific physical exam topic such as cirrhosis, endocarditis, or for example, JVP evaluation. We, using videos and different slides, we showed how to model the correct physical exam maneuver, and we also discussed the evidence behind it. And then finally, now that they've acquired these skills, we shared some resources and techniques on how to teach learners at the bedside these physical exam skills, primarily using the 5-minute moment technique from the Society of Bedside Medicine. One of the highlights was actually that by using historical context, we're able to teach our learners physical exam skills. For example, on the left, you have Pope Peter from the 11th century, who actually suffered from what we think now is a median nerve damage. And that's why this specific finding on physical exam is called the Pope's hand. On the right upper quadrant, you see a liver clay from ancient Babylonian times. Babylonian priests used to think that the soul, the site of the soul was actually in the liver, and they used these clay models to have these religious inscriptions on them. And at the bottom right, you have one of the earliest models of a stethoscope. So really using these historical contexts while you're describing, for example, the liver exam can help cement this information in your learner's mind. So what were the results of this intervention? They were actually a lot better than anticipated. So 82% of respondents said that they used the skills that they learned on the course at least 1 to 2 times during their 2-week board block. And 57 responded that actually what they learned had impacted their diagnosis, workup, and management of their patient, which really ties into the high value care that Taylor was talking about earlier. And then almost everyone, 89%, said that they had learned something new from the course. And we do hope to continue this course next year and maybe even expand it to include other learners as well. So all of these innovations in medical education will translate into increased scholarly output. So here we highlight the achievements that our residents have achieved at the state level and all these different achievements they've had at Virginia ACP this year. And this also highlights some of the conferences that our residents have participated in during this year as well. One way that we've been disseminating and sharing all of our achievements and information has been through social media. So this is a picture of the homepage of our Twitter page. For example, in addition to highlighting some of the resident scholarly activity program updates, we've also been sharing medical knowledge as well. For example, this is our monthly back to bedside tutorial, which talks about the importance of the physical exam. To highlight some of the impact that we've had on social media, here are some figures and numbers that we've had from Twitter over this past year. And over here on the right, you have our Twitter and Instagram handle. So if you don't follow us already, we really suggest that you do by the end of this lecture. And I'm going to hand this over to Zoe.
Thank you, Rasha. So in addition to bringing humanism back to the practice of medicine and the medical education, which as Rasha has demonstrated, translated to a lot of significant scholarly achievements and engagement by our residents, we also as a program this year made significant strides on bringing humanism into the culture of medicine and improving our environment, our training environment from the lenses of diversity, equity, and inclusion. And this is what I'll be focusing on. We are very privileged to work in a major tertiary care center that also serves as a safety net to a very diverse and often underserved patient population. As such, our program recognizes the importance of training physicians who recognize diversity in each other and importantly also in our patients. This year, we're very proud to share several key initiatives and developments in this area. This includes the start of a diversity, equity, inclusivity committee that is entirely resident run and driven, a peer mentorship structure that we will be piloting in which current residents will be paired with incoming intern residents. We restructured our intern health disparities retreat into an interactive workshop-based experience. And we also supported residents in participating in career development opportunities in diversity within healthcare. These efforts go hand in hand with our program's mission for and commitment to diversity, equity, and inclusion. We believe that fostering diversity in our trainees allows for greater shared knowledge and a broader perspective that enhances the care we provide to our patients. And we also strive towards creating an environment where there is a sense of belonging among our diverse community members. And that through this, we are allowed for individuals in this community to be privy to equitable experiences in diverse settings. The DEI committee, as I have mentioned, is a program supported by resident-run and driven committee. Residents identify initiatives that are important to them with the aim of fostering an environment in which differences are celebrated and encouraged. These initiatives this year have included social media highlights, including DEI-based topics, resident features on our website and social media space, interactive panels on key discussion points such as workplace microaggressions, and as mentioned, a peer mentorship structure that pairs incoming interns with current residents. We're particularly proud of our peer mentorship pilots. And this is important as identified by 61 of 86 of our correspondents within our internal program survey, because it provides a unique system for peer support that is different from the career mentorship they receive elsewhere. As mentioned, this is a unique opportunity where interns are paired with rising residents or current residents, and it allows them to really have a system of support to navigate the experience of residency that we know is rewarding but challenging. Our residents' commitment to this effort is demonstrated in their participation, with 83% of incoming interns and 57% of current non-graduating residents participating. And we are very excited to pilot this and then also assess the impact of this on our program. Beyond the DEI committee initiatives, we also expanded on structured education-focused topics like health disparities. One particular effort in this realm is our restructuring of the intern health disparities retreat, with special thanks to our APD for health disparities, Dr. Sarita Modi. Instead of the traditional or past poverty simulation that our interns have participated in, this year we rebuilt the intern health disparities retreats to focus on small group-based interactive activities with faculty across the GME. These workshops focused on enhancing the appreciation and understanding of health disparities that our patients face. And this involved robust discussions on topics such as the social determinants of health and the cycle of poverty. Importantly, this was a learning experience for all, both faculty and residents alike. And it also offered us a very unique opportunity to partner with a community center called the Neighborhood Center that serves the needs of the greater Fulton area, where many of our patients come from, and allowed us to better understand the resources that are available in a community setting to our patients. Overall, the intern health disparities retreat was very positively received, with feedback that focused on very positive comments on the structure of the retreat, which is discussion and small group based, the quality of the speakers we have brought into the retreat, the topics that we selected, and the opportunity to connect with the community. And when surveyed, interns and faculty participants were asked to what extent the workshops changed their view on matters such as empathy towards those facing poverty, or understanding and appreciation of the financial social pressures facing those in poverty. And the majority noted that the workshops moderately to significantly shifted their perspective, as noted by the light and dark blue bars, versus little to none, as noted by the light orange and dark orange bars. One future direction for this retreat is to equip our residents with tools to better address and problem solve in this critical space. In addition to internal program efforts, our program also committed to supporting residents in national development opportunities. And this year, we were very lucky to send one of our current interns, Dr. Rose Can, to the AMA and University of Cincinnati Resident Diversity Leadership Program. This is a selective year-long longitudinal program consisting of 30 to 40 residents across resident programs in the country. And residents that are part of this program get to participate in workshop sessions, meetings with leaders in healthcare, mentorship, in-person community building sessions, and also present in person at the end of the year AMA meeting in Chicago. We're very excited for our residents to continue to have opportunities like this and also share what they learned from opportunities like this with us. And with that, I'll pass it down to Neha.
Thank you, Zoe. Okay, so I'm going to talk about humanism and wellness. So how does wellness relate to humanism? Well, humanism is the basis of medicine. It provides healthcare with honesty, empathy, and compassion. But in order to provide that humanistic care that is so fundamentally important to internal medicine, it is important to consider the well-being of our health staff. It goes without saying that residency is an inherently stressful time, and add a pandemic on top of that. What is so admirable about our own residents is their own drive to support one another over the past several years. The Resident Wellness Committee is a completely resident-run group whose goal is to simply improve the resident experience. The committee is made up of residents who are committed to preventing burnout, providing resources to treat burnout, and to help their co-residents develop habits of self-care and healthy living. We recently asked our residents what contributed to their overall well-being. They said time away from work, understandably, quality time with friends and family, sleep, and what warmed all of our hearts was the CoResident Answer. One essential factor with regards to our wellness is the ability to recognize when our peers need support and a systematic way to provide that support. Stress First Aid is a national peer support training program with the goal to provide tools to help improve recovery from stress reactions, both in ourselves and towards our coworkers. It provides tools to help that recovery stress reaction. And so several of our members of our house staff, ranging from interns all the way to chief residents, volunteered to undergo this 4-hour training here at VCU. At the conclusion of the training, our residents felt comfortable practicing what we call the 7 C's, which aims at recognizing the onset of the stressor and continues all the way to wellness of the individual. In addition to completing the training, our residents volunteered to be identified as trained in this method in the circumstance that a fellow co-resident might need some help. Another area to highlight was our Mental Health Week, which was inspired by the WHO's World Mental Health Day. This was a week dedicated to highlighting the importance of our mental health, whether it's providing resources or different ways to emphasize self-care in whatever form that might look like. We hosted our colleagues in EAP who gave a talk to our residents about resources that might be available to them, as well as discussing different tools to manage stress and anxiety. In addition to this, we wanted to emphasize the importance of stepping outside of the hospital when need be. We provided afternoons where we had lunch outside, we played cornhole, and we utilized one of our favorite resources here at VCU, which is our Dogs on Call. Again, what made us proud was the fact that all of these initiatives were driven by our own residents. Another experience our residents felt enhanced their wellness is being involved in the community outside of the hospital. This has been a desire of our residents for several years, but given the pandemic, this has been difficult to execute. We are proud that this year we started to make connections with several organizations within the community with the plan of expanding throughout the coming years. Our holiday fundraiser this year was raising money for Feed More, an organization well known to our department as we fundraise for them annually. This organization is dedicated to feeding those who are food insecure in the community, many for whom we care for in the hospital. We are very excited to say that thanks to our residents, our program leadership, and faculty, We raised over $4,000 this year. In addition, we now have partnered with the Neighborhood Resource Center, which we were introduced to during our intern retreat. The Neighborhood Resource Center is based out of the East End of Richmond, and it provides numerous resources to that community, including nutritional education, financial advice, job advice, and a community garden. Several of our residents were able to participate in their first community garden cleanup this year, and we plan on continuing our efforts with them by participating in their nutritional education program in the fall. And over half of our residents agreed that planned social activities by the Program Wellness Committee contributed towards their wellness. Our social committee was able to pull off several events throughout the year, which our residents all seem to enjoy quite a lot. And nothing sells wellness more than coffee and food. As such, we have continued the time-honored tradition of Chief Brown Rounds, where we bring coffee to our residents while they're hard at work. But this year, we decided to change things up a bit too. We have a featured Mocktail Monday, which was perceived to be quite fun with the residents, as well as a Hot Chocolate Thursday here at the VA. And although this might seem small, we recognize as a Chief class that part of supporting the well-being of our residents is simply having a presence. This in itself has been one of our biggest goals of the year. We found that even daily check-ins have allowed us to cultivate meaningful relationships with the house staff, which has been a highlight of our year.
So we hope that we've shown how we revitalize resident education, that innovation, humanism can truly go hand in hand. And so on a program and personal level, from the absolute bottom of our hearts, we thank you all. To both the residents and the faculty, we've been amazingly proud to serve as your all chief residents over the last year. And we're all personally grateful to be part of your resident development and just a part of your year and your growth. And above all else too, our amazing program director, Dr. Forrest, definitely could have not gotten through this year with the stresses and things like that. She relayed all of them completely and really served as an amazing mentor for all of us. And so we appreciate her time, her patience, and her teaching. So thank you all very much.
And with that, we'll take any questions.
Thank you. Really appreciate it that you all have shown passion throughout the year and many great programs and accomplishments. So thank you. I appreciate that. We open it up for anyone for reflections or comments on the presentation. Dr. Syme.
Oh, sorry, I'm just struggling with my camera here. Yeah, amazing presentation. Thank you, for the presentation today and the amazing amount of things that somehow you managed to cram into 26 hours in every 24-hour day. It's truly impressive. And I think you've captured many of the things that are important, not just to chief residents, but important to us all, a sense of meaning and a sense of belonging and wellness, which we all have to focus on. As chief residents and throughout our careers. So I just want to say thank you from the department, from the patients and from our health system for all that you do every day. And the way that you help to lead others is really important, and you should be very proud of your accomplishments this year. So I know on behalf of the department, but bigger than the department, on behalf of our health system, thank you so much for all you do.
Thank you.
Thank you.
And I know you all are essentially, you'll end up in 5 different areas. I hope you'll stay in touch, and I hope that you will take your experiences here and inflict that on the future institutions wherever you are. So, you've set up amazing programs and done things. So I think you can change lives at other programs too. So I hope you will encourage that energy as you make the transition to fellows and to attending physicians. So I appreciate that.
Thank you so much.
I do actually have an ask from you. I know you'll do this, but please do let us know about your successes, because we see you as an extension of our family and we'll be forever following your careers. So please let us know about not just your professional, but your personal successes and joys. And we're happy to continue to support you. And hopefully it just expands our network as you go off into the world.
Thank you.
We will too.
We have many congratulations in the chat box from Brenda Queen and from Todd Gare saying, congratulations, thank you for all your work. good luck with your futures. We do have one question in the chat box here from Aaron Boyd. I was very interested to hear about the program regarding increasing time with patients. How do you plan to keep that going in the future? Or in other words, what guidance for future chiefs and future leaders?
I think I can speak on that because one of the initiatives we talked about was the EPIC course. But one thing is that people don't realize about bedside rounding is that it actually is more efficient than maybe traditional table rounds or speaking outside the hallway. It takes less time overall, but it maximizes that time with the patients. So we hope that by using the physical exam aspect as an excuse kind of to go back at the bedside, and also just increasing physically touching our patients and examining them enhances that. So it's more quality time spent with our patients. And we hope to expand this further with residents at some point in the future as well.
Do you have any guidance for folks on chalk talks? So, just quick comment here. You mentioned that, the morning rounds, residents like the interactive back and forth, the clinical problem solvers, that you've set up. One of the chief opportunities for chief residents and senior residents is chalk talks for, medical students where you walk through something. Do you have any experiences or thoughts to share as you train all levels of learners from, M3s, M4s up towards interns, residents, and even co-fellows and attendings in the future? Do you have any tips on how to make the engagement, the back and forth dialogue the best?
I think I can take this one. So I think one of the things that our efforts really shown to me is that effective teaching and education for our medical students don't always have to actually take the form of a chalk talk. That's certainly one of the aspects that we use and practice. And I set time to try to do a chalk talk once a day or every other day with my medical students. But one thing I actually have learned through Rasha's efforts in the enhancing physical exam curriculum was that I set time for my medical students to take them to the bedside of patients when I attend the service. And I highlight to them a physical exam that's prominent and interesting on a patient and allow them to see what normal is, what abnormal is. And so I thought that one advice I would give and something I personally learned is that chalk talks does not have to be the only format for effective interactive teaching and education. And I was grateful for the EPIC curriculum to actually give me ideas on how to be a more effective teacher.
And just to highlight, Drs. Nate Warner and Pat Fadden have started with a new M3 class, a physical exam bingo. Some medical students are kind of competing against each other to reach bingo. But the goal is to see as many physical exam findings as possible. So I encourage everyone who's on boards right now to discuss this with your med students. And me and my medical student today, we're trying to find some findings on the bingo. So that's another way.
Thank you. Any other comments from faculty, or if we have any co-residents on here, feel free to, this is your opportunity to critique the chiefs on their year. I have another follow. I could probably talk for another 15 minutes, but I'm not going to hold everybody. But just a comment. We mentioned humanism, and I wondered, throughout the year, we've had a lot of grand rounds talks on racism and structural racism. And I was just wondering, if you all have learned anything throughout the last year on, interacting with learners, particularly around, I think one of our last talks here at Grand Rounds was just we need to call out when we see, structural racism being used in medicine. And I wondered if you had any personal stories or any ways to reflect over the last year, any opportunities that you see where we could do better as learners and teachers?
Yeah, I think I can speak to that. We talk about humanism in medicine, like you say, and I think so much of what we enjoy doing in the hospital is getting to know our patients. And in the setting of our patient population and trying to, understand the disparities we see in healthcare, so much of it can be solved by just taking that time to sit with the patient and beyond their medical problems, understanding their home situation, their work situation, and that in itself, taking that 5 or 10 extra minutes, every day has really truly been one of the most effective ways that we've seen that we've been able to treat our patients. To the points of racism and things like that and microaggressions, I know Zoe and I are both involved with our Virginia ACP, and we did do a panel on this, and I think so much of what we learned is exactly what you said. When there are microaggressions noted, when dealing with patients or even in interactions amongst health staff and faculty, the most important thing that we can do is to, one, call it out, but two, education. And so I think a lot of what Zoe and the DEI committee is working towards is that education portion, which I think will not only make us, better physicians, but also really help us connect even better with our patients.
All right. Well, again, thank you so much for everything, for the presentation and everything you've done over the last 4 years. It wasn't just this year, also the years before that, as you were interns and residents here. So thank you for everything you do, and we wish you best of luck in the future. And so any other last minute thoughts? Dr. Stephanie Meyer just wanted to express her thanks also, Dr. Georgia McIntosh, Aaron Boyd. So lots of thanks going all around. So thank you.
Thank you all.
Thank you.
We will miss
Thank you.
everyone.
Best of luck.
Thank you.
Thank you.
Just proud you will.
Yeah, keep us updated, please. It's very important after you leave the institution. You may even come back in a few years for a grand round. So please, stay in touch.
We will.
Oh, don't worry. We plan to have you help us recruit residents. Don't you worry. You are our secret weapons.
Yeah, thank you all.
Thank you. Appreciate it.
Thank you. That concludes our Department of Internal Medicine grand rounds for today. We will have the CME code in the chat and the QR code available in a minute. And just to remind everyone, we have 2 more grand rounds for the remainder of this season. So thank you so much. I hope you all have a good rest of the afternoon. Take care.